Got a
We
big
have
weight.
AC in our houses.
And the online lecture that goes with the chapter is pretty good at walking you through those markers and how they behave in normal and in lymphoma. Okay, so let's look at the first thing here. Shane, you want to start us off? What do you see?
So it looks like there's maybe an ulceration there, and there's a diffuse and sort of maybe epidermotropic infiltrate.
Okay, so there's an infiltrate that's diffuse and epidermotropic. So, in this chapter it may shock you, but a lot of things will have lymphocytes, right?
Mm-hmm.
The things that aren't lymphocytes, what else is here?
EOs are there.
Yeah, lots of EOs.
Mm-hmm.
So does MF commonly get EOs?
If it's follicular.
So folliculotropic MF and tumor stage MF. Other than that, usually no. So patch MF, absolutely no. Plaque MF, sometimes. Tumor, real common. Folliculotropic, real common. So when EOs are present, that goes pretty strongly against B. T, lymphoma, only if folliculotropic or tumor stage, pretty much. And then there's some other lymphoproliferative things that tend to have lots of EOs. So any other kind of lymphoproliferative thing that has EOs?
LYP usually has like a
LYP. So looking at this, see how it's raised as a bump and kind of tapers down on the side?
Mm-hmm.
So it would have been a papule, and the center is dead, so it would have been papulonecrotic clinically, a papule with a dead center. Then you start looking at the cells and you look at the nuclei. There are lots and lots of cells that have mitoses, and the mitotic population are the large gray cells, and they tend to have nuclei like that, almost an owl's eye type of nucleus with a big prominent nucleolus. Very similar to a Reed-Sternberg cell in Hodgkin's. So, that's the kind of cell right there that you would expect to be CD30 positive. Oops, for those online, I'm saying that one right there and they can't see it. So, okay, so that's our mitotic figure there, and that's a really good Reed-Sternberg type cell right here. So, and there are plenty of those. So over here you got one, and up there, so lots of those Reed-Sternberg type cells. You'd expect all of those to be CD30 positive. The other thing that could have EOs and atypical CD30 positive cells is a bug bite, right? In a bug bite, your CD30 cells are going to be scattered, and LYPs are going to be sheets and clusters. So lymphoma or lymphomatoid papulosis, you have sheets and clusters of CD30 cells. In a bug bite, each CD30 cell sits by itself. Never in clusters, never in sheets. So that's kind of your differential for that. And this one is a little folliculotropic. So, the other thing that would be in the differential for this would be a tumor stage MF. Tumor stage MF often has EOs, often has CD30 transformation. Prognosis for lymphomatoid papulosis, good. Prognosis for transformed CD30 positive MF, horrible. How are you going to tell them apart ultimately? Clinical. Right? If the person has little papulonecrotic lesions, that's lymphomatoid papulosis. If they have patches and then tumors, that's MF. What complicates it is MF patients commonly get lymphomatoid papulosis. So it's very common for your MF patients to get relapsing crops of little LYP lesions. if you treat their MF, just about anything you treat their MF with, the MF responds, the LYP doesn't. If you look at clonality, it's the same clone. So why does the same clone respond beautifully to narrowband or methotrexate or whatever you're throwing at it, but the LYP part just laughs at whatever therapy you're doing? No one knows. But very important, because you expect that population to be refractory to treatment. If it's just LYP, you can safely ignore it. If it's large cell transformation, that's really bad and needs more aggressive therapy. So teasing those out is important. LYP, each little papule is going to self-heal. It's going to be small. It's going to be transient. It's going to heal. It's just you keep getting more. Tumor stage MF, CD30 positive, doesn't resolve. So clinical trumps everything else in that setting. So, okay. Let's go ahead.
Diffuse infiltrate down into fat.
Yeah. So if you had to say top heavy or bottom heavy, what would this be?
A little bit more bottom heavy.
A little more bottom heavy. Top heavy tends to be benign. Bottom heavy tends to be lymphoma. The next thing you do is you look at your hair follicles and your blood vessels. So you see if you can find any follicles, not so much in this particular one. There's an erector pili, but the follicular epithelium, certainly isn't prominent. And you look at your blood vessels. Your blood vessels pretty much have normal lumen. In a reactive infiltrate, the blood vessels and the epithelium tend to be reactive. So you have PEH, hyperplasia of the follicular epithelium, you have endothelial swelling, proliferation of blood vessels. In lymphoma, you have this infiltrate that, if anything, is bigger, and yet there's less reaction. It's like you want to shake the follicle and say, "Don't you see what's going on all around you?" In reactive, you get a little bit of inflammation and a lot of reaction of the follicle. In lymphoma, you've got disproportionate big infiltrate, and yet the blood vessels, the follicles, they're oblivious to all the squalor around them. So those are all clues at scan for lymphoma versus not lymphoma. Now you look at the cells here. And yeah, they're kind of big, right? If you look at the nuclei themselves, do the nuclei tend to be cleaved or round?
They look pretty round.
They look pretty round. So a round cell is a blast, right? Round nucleus is a blast. So a cleaved cell is a site. A round cell is a blast. So anytime anyone's talking about a centrocyte versus a centroblast, if you make a B has a circle. A capital B has two circles. Helps remember it's round. A C is cleaved, right? So sites are cleaved, blasts are round. Immunoblast has the nucleus smack dead in the center like a bullseye. Centroblast has the nucleolus on the side.
When you say cleave, what's that look like histologically? Is it just like a notch out of the...
Yeah. So instead of being a round nucleus, it's got a notch cut out of it. So if anything, these are blasts and sheets of blasts. So lymphomas with centrocytes are better differentiated. Blastic lymphomas are more primitive. They're more poorly differentiated. So if this were, let me give you an example. Say this were on the leg of a 96-year-old woman, and it stained CD20 positive. It was CD10 negative, but still had BCL6. Can't make out any germinal centers at all when you do a CD21. So dendritic network, I mean, there are really no dendritic network showing preserved germinal centers. They're all long since wiped out. But it's BCL2 positive. And it's MUM1 positive. What are you thinking?
Fuse large cell. What type?
Yeah.
Fuse large cell. Fuse
I mean, so old women, 90-plus-year-old women, get an aggressive type of blastic lymphoma on the leg that is leg-type lymphoma. It's an activated, nasty, blastic follicle center lymphoma. It has picked up BCL2 expression, usually lost CD10, about 50-50 whether it retains BCL6 or not. MIB fraction, a little higher than most other lymphomas, maybe 50%, but not 100% like a normal germinal center. And usually you can't make out any follicular network with a CD21 or 23. So you see sheets of cells, and then we have to look at the cells a little higher. You definitely have blasts that are round. As you look around, you're looking to see, do you have cleaved nuclei as well? Actually, most of them look blast-like in this particular example. So let's see how it stained. Oh, you can also see the striated muscle, suggesting that this is head and neck. This particular one is an eyelid mass. And so this is the report you get back. It was CD20 positive. What does that mean?
B.
79A positive. What does that mean?
Additionally, B forever.
PAX5 positive.
Similarly, mysteriously, B. At some
Yeah,
point
it's
in the
one of
life
those
cycle
we don't
became
use
a lot.
that as often. It was BCL2 positive.
So we're thinking germinal, not germinal center.
So usually that would go with marginal or with a bad blastic type of germinal center. You know, they have to be pretty bad before they pick up BCL2 or systemic lymphoma. That's the other possibility. It is focally BCL6 positive, so that means what to you?
Focally, BCL6.
Yeah.
So that would be the germinal center.
Yeah, so something suggesting it has germinal center differentiation. It's blastic, that's why it picked up BCL2. CD10 was negative. You'd expect that to be lost pretty early as germinal centers become malignant. CD3 was negative. So now we have basically a diffuse large B lymphoma. And you're still not sure, is this systemic lymphoma or is this a primary cutaneous? And so the patient needs to be staged.
And this is not the time where ALK1 is
Okay.
That is not, that's for CD30 lymphomas. So primary cutaneous CD30 lymphoma is ALK1, systemic lymphomas are typically ALK1 positive. Primary cutaneous, commonly negative. When the systemic are negative, they have a horrible prognosis. So we're used to saying negative, great, primary cutaneous, but if it's systemic and it's negative, that's not so great. So, they still have to be staged. Okay.
So there is a Deletion diffuse infiltrate that looks periadonexal, perivascular, and then hypernodular in the dermis.
Yeah, and so if you had to commit yourself, would you say the aggregates are horizontally oriented or more vertically oriented?
Probably more horizontal. Okay, you're telling me vertical. So, okay.
So when you look at one like that, it looks almost like a lupus infiltrate, the way it's vertical along a hair follicle, right? And then
Amber or flash flood?
that just means the tide's coming in, right? And it's still raining. Okay. When we looked at our other lymphomas, they were blue, right? When you look at this, it's kind of pinky gray. Exactly. It's more amphiphilic, pinky gray. So it's pinky gray. It's vertically oriented. That's typical for marginal zone.
Okay.
So most T lymphomas form a band up under the epidermis. Most B lymphomas are a bottom-heavy nodule. Marginal zone at scan is vertically oriented like lupus, and it's gray to amphiphilic. So something that's vertically oriented in the center, pretty heavy, pretty dense. I certainly don't see follicular hyperplasia or epidermal hyperplasia suggesting a reactive infiltrate. So I'm thinking probably lymphoma, but it's vertically oriented, middle of the dermis. So I'm thinking probably marginal. So how would you expect it to stain?
So it would be CD3, CD79, BCL.
So you said CD3?
Sorry, CD20,
CD20, 79.
BCL2 positive, BCL6 negative.
Yep.
And then depending the stage, like CD10 positive.
This is also, the CD10, that's for follicle center.
Sorry.
That's follicle centers. Normal follicle center has CD10. It's the first thing lost as they start going bad, right? So a really well-differentiated follicular pattern follicle center lymphoma may still have CD10. By the time it becomes diffuse, it's usually lost. For the marginal zone, you'd expect all your markers to be negative unless you have normal germinal centers in there. So marginal zone lymphoma can form around totally benign germinal centers.
When you say all your markers, you mean BCLs and... I'm sorry, I don't know what you mean by all your markers.
How did I say it?
You said all your markers would be negative, so I didn't know, like...
We have the best markers.
Which markers are
Okay,
negative.
sorry. Let's start that over again. So follicle center markers BCL6, CD10 would usually be negative in a marginal zone lymphoma unless there are benign germinal centers there. One of the common patterns for marginal zone lymphoma is to have big round germinal centers and then all this gray stuff spread out between them. That's the lymphoma. The germinal centers themselves are benign. How do you know they're benign? They have a perfectly intact CD21 network. Their MIB is 100% positive with the gradient. They normally express BCL6 and CD10, but just restricted to that germinal center like a normal goldfish in a fishbowl. In lymphoma, you get what's called the piranha sign, where those BCL6 cells jump out of the fishbowl and they're out where they don't belong. In benign reactive, they stay, the BCL6 stay where they're supposed to stay. The BCL2s stay where they're supposed to stay. In marginal zone lymphoma, if you have germinal centers, those germinal centers can be invaded by the malignant marginal zone cells. So what you see is all the CD10 and BCL6 stay where they're supposed to stay. But the BCL2 don't respect their boundaries. They start invading into those germinal centers. In follicle center lymphoma, it's just the other way around. The nasty piranhas start jumping out of the goldfish bowl, out where they're not supposed to be.
Dr. Elston, just so you know, in terms of the reading, we broke it up so that this week they just did T-cell and LRP,
and next week
and
we're
next
doing
week
B.
they're doing B-cell.
Okay, so you got a good preview for next week. Sorry,
It's okay.
did
When
not
we got lecture over the
realize.
stains, I was like, I don't
It was
know.
a good-
Sure what
Okay,
So Nicole's doing all the B-cell unknowns next week.
got
So
it.
just so you know. That's
Okay, thank you for pointing that out, because that's important stuff to learn and cover. Unfortunately, on my schedule, it said lymphoma, but okay,
And the boxes are mixed.
got it. Yep. So let's pull. So today we're covering mainly MF is what was in the reading.
And leukemia.
Okay. Okay. Anything not B. Okay. And now you're all prepared for next week. Okay. So you kept them split out.
Yikes.
Okay.
I was looking familiar.
There we go. You got your marginal zone.
That was a helpful preview.
Okay. A helpful preview. Very good.
Repetition is always helpful with lymphomas.
Yes.
And the other thing is, thank you for speaking up. Don't sit there politely. Just say something.
Theoretically, we should.
You don't know what you don't know.
We should have been before, so we should have.
Okay, good.
So it's like bacular interface with lymph in every hole and up along the DEJ.
Okay, so if you had an interface dermatitis with a lymph in every hole, your basal layer intact, a lymph in every hole, what's your differential?
So enough. enough. And then I would also go with.
So what reactive things can do that?
So like a
Yeah, pityriasis lichenoides, either acuta
Leva
or
or PLC,
early evolving stage of a BLK,
lichenoid drug.
and then syphilis can do it too. Syphilis is commonly pseudolymphomatous. So syphilis can do it. Pityriasis lichenoides can do it. Early evolving benign lichenoid keratosis can do it. It's one of the reasons why, both BLK, lichenoid, and lichen planus like keratosis, bit of a misnomer because in the early stage it's not lichenoid. It's vacuolar, lymph in every hole. So in this case, let's walk through it. First off, you have a little parakeratosis, which is actually unusual in MF. MF is usually a compact orthokeratotic cornea. You have basilar tagging. You have papillodermal fibrosis. which is just a sign of chronicity. You have a perivascular infiltrate, and in at least some examples, I think you can see it well over here, the infiltrate, there's much more of it above the vessel than below the vessel. So you have a bare underbelly to the vessel, right? Naked underbelly, bare underbelly, with most of the infiltrate above. And if you compare the lymphocytes in the epidermis to the lymphocytes below, the lymphocytes in the epidermis are large, hyperchromatic, and angulated. So large, hyperchromatic, angulated lymphs in the epidermis when compared to the lymphs down below in the dermis, most of which are benign. If you look at deletion markers, things like CD7, you want to have the new criteria are that the malignant population here should have 90% loss of CD7 when compared to the benign recruited lymphocytes in the dermis. They used to say 50. The problem is CD7 is always a weak. It's always weaker. And so people were over-reading loss, and so they said, it ought to be 90%. A really dramatic loss of CD7 in order to call it. Okay, so once again, real quick, compact, usually orthokeratotic, not parakeratotic like this one. Basilar tagging, lymph in every hole. The lymphocytes are large, dark, angulated. Papillodermal fibrosis, bare underbelly to the infiltrate around the vessels.
Dense and diffuse infiltrate.
So kind of dense and diffuse, epidermotropic. And let's look at the lymphs.
Yeah, larger atypical open vesicular nuclei.
So when you say open and vesicular, usually what I want for vesicular, like this one here is pretty good for vesicular. It has a dark chromatin rim and then pretty, clear white pale in the center. A lot of these have too much chromatin for me to say they're vesicular. The whole thing is gray all the way across. There's no white. The reason it becomes important is like large cell Bs tend to have a vesicular nucleus. This thing has more gray chromatin and very, very prominent, large, irregular nucleoli.
Anaplastic large cell.
More like an ALCL type nucleus, one that you might expect to be Key1 positive. So Key1 is CD30, same thing. Lots of markers have two names. Just like, someone's name might be William and Bill. Key1 is CD30, same thing, right? So when you see these, they look different from a B cell. And one of it is that they retain much more gray nucleoplasm throughout, have the prominent nucleoli. So they're, that's a cell where you reach for your CD30, your Key1. And you have Key1 cells in sheets. And the patient, so I'm the patient. I have CD30 cells in sheets, and I have a huge tumor on my arm that's progressing and not going away.
So it's not LYP, it's the anaplastic large cell lymphoma. Or it could have systemic involvement.
So ALCL, and so you'll get an ALK1, but you'll also stage, and you'll look for retroperitoneal adenopathy and all of those things. But I lied. I actually have, they come up like tumors with sheets of cells, but then they go away, and then the next one comes up, and then that one goes away, and the next one comes up, and then that one goes away.
LYP type C.
Correct. Primary cutaneous anaplastic large cell lymphoma can behave a lot like LYP type C. So, I mean, they still discuss both in textbooks. For the life of me, I don't think there's a difference. I think LYP type C is primary cutaneous large cell and ALCL, anaplastic large cell lymphoma. It undergoes a spontaneously regressing course. Important to know because we see lots of patients, and over the years it's been 10, 20 patients who developed nodules. They were put on systemic chemo. The nodules went away. What would have happened if they hadn't been put on systemic chemo? Nodules wouldn't have gone away, right? If there were no chemo involved, what would have happened over the next 6 months? New nodules, right? But now they got put on chemo, all the nodules went away. Now they get new nodules. Well, they get labeled as recurrent lymphoma. Now they go on a more aggressive regimen. The nodules all go away, then new nodules come. They get put on a more aggressive regimen. Then they get put on a transplant list. Then they get their transplant. You know, all for something that would have responded to low-dose methotrexate, like lymphomatoid papulosis. So, you know, you see people treated very aggressively for primary cutaneous anaplastic large cell lymphoma, ALCL. Remember that it's basically the same as type C LYP, and you treat it like LYP, and you don't treat it aggressively because it just leads to a cycle of relapse and more aggressive and more aggressive and more aggressive therapy, which is not in the best interest of the patient. We had one of our residents, when I was in Texas, her husband was the chief of oncology, and you know, she was very uncomfortable with that whole conversation, and so she went home and she asked her husband, so, you know, how do you treat primary cutaneous large cell anaplastic lymphoma? And he said, well, in our residency in Boston, we were told not to because you get people in trouble and you hurt them, and it's some kind of witchcraft that the derms do, and so you send them to the derms and you don't touch them. And she said, okay. You know, fortunately, he had been taught by staff who had probably been burnt at some point and, you know, knew to teach that these are different and you don't treat them like a systemic lymphoma. Okay, let's see.
Looks like a pretty dense perivascular.
Yeah, there's unfortunately, there's some crud on the slide, but. So kind of dense perivascular infiltrate, and we're going to look and describe the cells.
Larger. Looks like a few of them have prominent nucleoli.
Very prominent irregular nuclei, usually one. And is it a truly vesicular nucleus, or is there gray nucleoplasm kind of all the way across?
Gray.
So any stain you might want to pull out on this kind of cell?
CD30.
Yep. And it's positive, and not surprisingly, because you can see the sheets and clusters. There's sheets and clusters. So is this a bug bite?
No.
No.
Primary cutaneous.
Nor is it scabies, because that can give you plenty, but never in sheets and clusters. So could this be CD30 lymphoma, ALCL?
Mm-hmm.
Could it be lymphomatoid papulosis? How are you going to tell?
Clinically.
Yeah, exactly.
Could be
By
the
the way
same
it
thing.
behaves. And
ALK1.
so absolutely ALK1 is a good idea. If it's ALK1 positive, that's probably systemic lymphoma. ALK1 negative, typical for skin, but 10% of systemic lymphomas are ALK1 negative, and those are the ones that are dead in 3 months. So, okay.
Dr. Russell, is that just
that was not true pigment in there? Or it almost looked like a tattoo.
I think it was formalin pigment on the
Okay.
slide, most likely. Okay.
So there seems to be a grand.
So there's a Grint zone. And
Once again, they have that big grayish kind of nuclei.
say a grayish
Although
nuclei,
there's no prominent nuclei.
no prominent nucleoli, and they're on a background of cytoplasm. See how they're on a background of pink?
Yeah.
So these cells, most of the lymphomas we saw were just nucleus. This has definite cytoplasm. We saw little of that with the marginal zone lymphomas. The other thing is, when you look at the nuclei, like this is a really good example right there where the pointer is. See that nuclear molding? So you have molding and you have peripheral cytoplasm. Suggests that these could be myeloid.
Okay.
Right. So at that point, you want to get a leader stain, myeloperoxidase, lysozyme, something that stains myeloid series. One of the problems is if you just do your lymphoid markers, leukemia picks up T cell markers. So leukemias commonly stain like a T cell, but the one they don't pick up is CD3. So if you have something that's picking up T cell markers, especially CD4, but is CD3 negative, that should make you think of leukemia. And one of the more common leukemias we see in skin at this point is the primary leukemia in skin, the blastic plasmacytoidendritic cell neoplasm. Excuse me, that is a primary cutaneous CD123 positive leukemia. And like other leukemias, it is commonly CD4 positive, a variety of other T cell markers, but CD3 negative. So 4 positive, 3 negative, think leukemia.
Also picks 56.
There. As with anything else, there are more and more markers available. But in day-to-day practice, you don't have to reach for most of them. And, the ones you should probably know cold are the ones that get used most commonly. Let's get that.
So this one is a superficial and deep nodular sort of perivascular periodontal infiltrate that extends down into the superficial fat. It looks like they're mostly smaller lymphocytes. Some may be in medium, but not that much cytoplasm to them, but they have a little bit. I'm not seeing like the big blastic type cells. These are mostly all small and medium sized cells.
Yeah.
And they look pretty monomorphic. I don't see much or any epidermotropism. So I would wonder if it's more of like a leukemia cutis that's like further on the spectrum in terms of development.
So, question would be, is it a B-cell lymphoma? Is it a leukemia cutis? So you depend on your markers. And this one is CD20 negative, CD3 negative, CD4 positive, leader positive.
I think it was family.
Yeah, so it's a leukemia.
So I would say this is pretty marked deep infiltrate of atypical looking lymphocytes. Certainly rimming adipocytes is really just deep. If there's really no epidermal involvement, you can think of subcutaneous paniculitis like T-cell lymphoma. These do have a little bit of cytoplasm to them, but they're certainly larger, atypical cells. Some of them have multiple nucleoli.
Yeah. So you're going to want
To
to
get some stains.
see how they stain, and these are CD20 positive and CD5 positive, like a T cell. They're BCL2 positive.
So the CD5 can go with, I think, mantle cell.
You are correct. It goes with mantle. So it goes with things like CLL and with mantle zone lymphoma. Mantle zone lymphomas, we don't see a whole lot of them in the skin, but that's, they would stain like CLL, which we do see a lot of in skin. Anyone who's going to be doing Mohs, Vic Marks at Geisinger, once, twice a year would tell the internist that their patient had lymphoma because he's chasing a basal cell. And one of the things you look for is lymphoid aggregates. You want to make sure that there's no tumor where there are lymphoid aggregates. But if the lymphoid aggregates are big and deep and everywhere and they just don't go away, and they're not T cell, they're B cell, your patient is CLL. And so he would, a couple of times a year, he would make the diagnosis in the Mohs lab on sections from a patient with a cutaneous tumor. So I'm really glad that we went through the B cell markers because there are some T lymphomas that express B markers. So if you have a T lymphoma that expresses BCL6, which is a follicle center marker, right? So it's telling you it's a follicular T cell. So it's a T lymphoma that's expressing BCL6. What are your T lymphomas that express BCL6?
The small, medium, pleomorphic.
So small, medium, pleomorphic lymphoma. Give me two others.
Isn't there like a primary cutaneous follicle?
Center lymphoma, which is like a monomorphous variant of small, medium, pleomorphic. And then the last one is the angioimmunoblastic lymphomas, which are a systemic lymphoma that presents in skin that is also a follicular T cell. So there are markers that are normally B, markers that are normally T. Remember, leukemia picks up some of the T markers. Follicular T cells pick up BCL6 or normally expressed BCL6. When they form lymphomas, they retain that BCL6. So that includes the small, medium, pleomorphic lymphoma, very good prognosis. Follicular T cell follicular lymphoma, very good prognosis. The angioimmunoblastic lymphoma, very bad prognosis. Okay, let's see what else. So, what do you see?
So, the epidermis is sort of maybe a face, but maybe a grin zone there. That's not really involved. It's just there's some giant cells with reef-like.
Yeah, some Langhans type giant cells.
Yeah. So maybe where the skin's, maybe it's a little more like undulated. They're like giant cells in like granulomatous-like skin.
So granulomatous slack skin or granulomatous MF would be two things. So you'd look for evidence of epidermotropism. There are a few cells with basilar tagging, and you know it may not matter that much because granulomatous lack skin, the majority of them go on to MF. And it's a clinical differential. If they've got big saggy areas of skin in this histology, then they've got granulomatous lack skin. Some go on to Hodgkin's, most go on to MF.
So we have a crested papule here, a lot of papillary germinal edema, and a lot of atypical cells. Looks sort of wedge-shaped, so that's sort of about a OIP.
Yeah, so you wonder about OIP. There are EOs present. It stains T cell. The patient also is Caribbean, so is Afro-Caribbean, has osteolytic lesions, chronic pruritus, chronic eczema for years.
HTLV1.
So you worry about HTLV1, which does a variety of things to include primary effusion lymphomas and cutaneous lymphomas, and also chronic refractory eczema. So I'm surprised, honestly, we don't see more of it here. In Pennsylvania, we rarely saw it. In New York, it depended where you practiced. If you practiced at St. Luke's, you didn't see it. If you practiced at Columbia, you had 100 patients with it because you had a big Dominican and more of a Caribbean population that was there. And so it was originally Japanese and Afro-Caribbean. And where you have those populations and you have chronic eczematous skin eruption, one of the things you have to screen for is HTLV1. We may have it, in your refractory eczemas, because Charleston has always had kind of a Caribbean connection. It's probably worth screening for in our really refractory eczema patients.
What's the best way to screen? Do you have to do a biopsy? Can you
blood test. Just blood test for HTLV1.
So this goes kind of superficial, mid, and deep into that.
Yeah, so kind of superficial, mid, and deep. And
mostly small, medium, typical lymphocytes.
yep. And you can make out a little bit of granularity in the cytoplasm. Granular lymphocytes are more likely to be cytotoxic type of lymphocytes. So a few ways to look at this. Deep, mid, superficial, just as you said, can be some things like gamma delta lymphomas often fall into that. Some of the NK lymphomas fall into that. The leukemias can fall into that. So it kind of directs you a little bit, and then it's your markers after that. Gamma delta lymphomas often have lots of necrotic nuclei, so lots of dead and necrotic, especially in the sub-Q, lots of pycnotic nuclei. The NK lymphomas are often angiocentric, angiodestructive, so they often ulcerate, have less commonly red cell extravasation because it's usually more vascular damage, so you get whole-scale tissue necrosis rather than just erythrocyte extravasation. So necrosis and angiocentricity suggests angiocentric angiodestructive lymphoma. All of those you're going to test for EBV because many of them are EBV positive. Okay, and we are out of time. So next time, you've had this great preview of B lymphomas.